We'll discuss the peritoneal recesses. Now, what are these peritoneal recesses? These are small pocket-like extensions of the peritoneal cavity enclosed by small peritoneal folds. So, best noticed in fetuses and often obliterates in adults. Sometimes they form potential site for internal hernia and strangulation. So, these are the categories of the various recesses. Subphrenic is beneath the diaphragm, then duodenal recesses in relation to the duodenum, and cecal recesses in relation to the cecum. Now first we will discuss the subdiaphragmatic spaces. So these spaces are in close proximity to the liver. They are of great surgical importance. Knowledge of their boundaries and communication is helpful in understanding the direction of the flow of peritoneal fluid. Now subphrenic or subdiaphragmatic spaces further classified into left and right, and left if further subcategorized it is left anterior and left posterior, right anterior and right posterior. So another name for right posterior is Morrison's pouch or hepatorenal pouch, and for left posterior it is lesser sac. So these are left posterior and right posterior, they are lying in relation to the liver, so that's why the another name is given subhepatic, that is left subhepatic and right subhepatic. Right and left subdiaphragmatic spaces are separated by the falciform ligament. Coming to the left anterior space, so boundaries are anteriorly, this is the space you can see in this diagram. Anteriorly, this is the anterior abdominal wall which is related to it. Then posteriorly, anterior surface of the left lobe of liver. Superiorly, left triangular ligament is there, and inferiorly the space is open with greater sac. You can see. So this is the space. Now on the right side, this space is limited by the falciform ligament. So this falciform ligament is separating the left anterior from the right anterior. Coming to the right anterior, right subdiaphragmatic space. So the boundaries are, so this is the space you can see here. Anteriorly again anterior abdominal wall, posteriorly anterior and superior surface of the liver, and superiorly the superior layer of the coronary ligament. Then inferiorly the space is open, and on the left side it is limited by falciform ligament. So these are the anterior spaces, that is right and left. Coming to the right posterior space, so that is, this is the right posterior space. Boundaries are, if we see, and superiorly inferior layer of, this is the superiorly, it is inferior layer of the coronary ligament. Then inferiorly the space is open into the right paracolic gutter through which it communicates with the pelvic cavity. Then anteriorly the visceral surface of the right lobe of the liver is there, you can see here. Posteriorly parietal peritoneum covering the right suprarenal and right kidney. On the left side the space is open and it is in communication with the lesser sac via epiploic foramen, you can see here. So this is it is in communication with the lesser sac which is lying behind the posterior surface of the stomach. The anatomical basis of this subphrenic space is hepatorenal pouch is the most dependent part of the peritoneal cavity in the supine position. The abscess fills the pouch in case of the perforated appendix, peptic ulcer, then cholecystitis, upper abdominal surgeries. Then because of the connection, the fluid from hepatorenal pouch can enter the pelvic cavity causing irritation of the local peritoneum. So such irritation in front of the iliac fossa may be mistaken for appendicitis. In perforated appendicitis, the abscess spreads upward along the right paracolic gutter. Coming to the left posterior intraperitoneal space or lesser sac, you can see here boundaries are largest peritoneal recess going from the greater sac behind the stomach, also called as the omental bursa. Closed on all sides except at the upper part of the right border of the sac, where it lies the epiploic foramen communicating the lesser sac with the hepatorenal pouch. So this is the left posterior space, or it is communicating with the hepatorenal pouch through the epiploic foramen. Now if we discuss the lesser sac separately, so what are the boundaries of lesser sac? It has two walls and four margins, anterior and posterior walls, and upper, lower, right and left margins. Now if we come to the anterior wall, from above downward you can see the caudate lobe of the liver. Here this is the boundary. Then lesser omentum, posterior inferior surface of the stomach, then anterior two layers of the greater omentum. The posterior wall from below upward is posterior two layers of the greater mentum, then transverse colon, transverse mesocolon, then pancreas, then upper part of the left kidney, left suprarenal, and diaphragm. So it is going like this. So this is the posterior wall. Margins are, upper margin is formed by the reflection of the peritoneum from the diaphragm to the caudate lobe of liver. Lower margin is represented by the transverse colon. Right margin, right free margin of the greater mentum. Left margin, left free margin of the greater mentum. So these are the four margins of the lesser sac. Now epiploic foramen, which is the communicating link between these two, that is lesser sac with hepatorenal pouch. It is large as half crown. The situation is at upper part of the right wall of lesser sac at the level of T12 vertebra. So the boundaries are, it has the anterior wall, then it has the posterior wall. You can see the diagram: anterior, posterior, superior and inferior. So anterior boundary is, so right free margin of the lesser sac containing bile duct, hepatic artery and portal vein. Posteriorly you can see the IVC and right suprarenal gland, and superiorly you can see the caudate process of the liver, and inferiorly is the first inch of the first part of the duodenum and horizontal part of the hepatic artery. Coming to the duodenal recesses. So number of duodenal recesses are lying in relation to the duodenum. First is the superior duodenal recess. It is seen in 50% of the individual lying at the level of L2 and orifice is facing downward. Then paraduodenal recess, which is seen in 20% of individuals, orifice is facing to the right, contain inferior mesenteric vein and its peritoneal fold. Then comes the inferior duodenal recess. It is seen in 75% of the individual. So this is the, you can see the most common, lies at the level of L3 vertebra and orifice is facing upwards. Then duodenojejunal recess, you can see here, present in 20% of the individual, orifice is facing downward. Then comes the retroduodenal recess, which is lying behind the duodenum. It is the largest recess, present occasionally. Orifice is about 8 to 10 centimeter deep and faces to the left. So you can see here. Then comes the mesenterico-parietal fossa of Walder or mesenterico-parietal recess, more frequently seen in fetuses, located behind the upper part of the mesentery, contain the superior mesenteric vessels and orifices facing towards the left. So these are the 6 important duodenal recesses which are lying in relation to the duodenum. Coming to the cecal recesses, which are lying in relation to the cecum, that is ileocolic. First is the ileocolic or superior ileocecal recess, located at the junction of terminal ileum and the beginning of the ascending colon. Orifice is facing downward and to the left, transmits a branch of ileocolic artery and its vein. Then inferior ileocecal recess, you can see, located at the junction of terminal ileum and cecum. Orifice is facing downward and to the left. This is referred as bloodless fold of Treves. Then retrocecal recess is located behind the cecum and often contain the appendix. Orifice is facing downward, you can see. So this is the retrocecal. So this is all about the recesses and the important classification of these recesses. So thank you very much.